So it's my pleasure now to start off the meeting with our first speaker, Dr. Jeff Lancet, who's chair of the Department of Malignant Hematology at the Moffitt Cancer Center in Tampa. Dr. Moffitt.
Thanks, Dr. Kadia, and it's a pleasure to be here. It's a little bit early for me, but it's a good thing. So I was asked to speak about CPX-351 and its current role and combinations and its future, which I'll try to do in the next 10 minutes. It's interesting, CPX-351 is one of those few drugs that kind of retained its original code name from the small pharmaceutical company that first developed it back, 20, 25 years ago. And really that name caught on as opposed to the trade name Vyxeos or the generic liposomal daunorubicin cytarabine name. So I've always found that kind of interesting. But for those who may not be familiar, CPX-351, it's nothing more than a bilamellar liposome that encapsulates daunorubicin and cytarabine in a fixed synergistic molar ratio, which then enters the cell as a lipid molecule, as you can see here in the blue color. And then several hours later, there's intracellular release in the cytoplasm, and the chemotherapy molecules are then taken up by the nucleus, as shown in the red fluorescence here. Within 24 hours. So the drugs are basically taken up by the cell at the same time, which is thought to be its main reason for pharmacokinetic advantages. The phase 3 that led to its approval in older adults with newly diagnosed secondary AML is shown here, with overall survival and response rates that were significantly higher with CPX-351 than with standard 7+3 induction. And I think importantly, survival that was landmarked from the time of transplant was superior in the CPX-351 treated patients compared to the 7+3 treated patients, and a modestly higher likelihood or rate of transplant occurred in the CPX arm compared to the 7+3 arm. And we're still trying to understand why this occurred. And the main signal that's come to light is that the improvement in survival seems to be driven not necessarily by improvement in relapse rates, but by a reduced transplant-related mortality that was correlated with the CPX-351 arm. A lot of work still going on to explore the reasons for that, but it was seemingly more of a toxicity related benefit than it was actually a disease-modifying benefit as far as we know right now, with the limitation being that we didn't have MRD testing available at the time of transplant to really understand the depth of molecular response going into transplant. What we've also learned more recently, and this data is becoming reproducible, and I'll show you more later, is that delving further into the molecular classification of AML, mainly the patients with AML and MDS-related mutations, it seems that the survival benefit that's attributable to CPX is primarily occurring in this specific subgroup of AML-MR, which didn't exist diagnostically when the study was first done several years ago. But retrospectively, looking at the mutation profile, it's really the AML-MR patients that are enjoying a survival advantage from CPX-351, and other groups such as genetically defined de novo AML or TP53 mutated AML, there's really no difference in outcomes. It's really the AML with MDS-related mutations that are driving the primary survival benefit from this phase 3 trial. And then, like I mentioned, one thing that the original trial did not have was MRD-based outcomes. So it wasn't really clear exactly how MRD rates between CPX compared to 7+3, and we still don't know for sure whether that might have been the primary driver of the benefit in addition to toxicity. Subsequent real-world analyses have been done. One of these is shown here by Dr. Clouzot and colleagues in France, and you can see that there is an overall survival benefit amongst patients who achieved MRD negativity within 2 cycles of therapy compared to those that did not. And the same survival benefit post-transplant was observed in this retrospective real-world analysis as well. The MRD negativity rate amongst the CR/CRI patients in the study was around 65%. So a good chunk of these patients who achieved CR were actually experiencing deep molecular response. Now, moving on to other randomized studies, I think the main one that was really a pivotal trial that distinguished between CPX and more conventional induction chemotherapy was the UK AML-19 trial shown here. And similar to what I showed you before in the subgroup analysis of the original CPX trial, in this particular trial, although there was not an overall survival advantage in the entire group attributed to CPX-351 compared to FLAG-IDA, in the exploratory molecular subgroup of those patients with MDS-related mutations, there was a statistically significant difference in survival favoring CPX over FLAG-IDA, and the same was not the case, again, for the TP53 mutated cases. And a deeper dive into the AML-MR subgroup was undertaken by Dr. Mehta and presented at ASH last year. And again, these mutations, the presence of these mutations, as I just mentioned, conferred an overall survival advantage with CPX, but at the same time also resulted in a reduced or an improved relapse-free survival in this group, and interestingly, a much lower cumulative incidence of death during remission. So again, speaking to the potential lower toxicity of this regimen compared to of CPX compared to more conventional regimens that might be driving some of the benefit, especially in this subgroup. So what about CPX in younger or clinically defined de novo AML? We don't really have randomized trial data yet available, but there are a couple of ongoing trials that are answering this question, or at least asking the question. There's the Alpha 2101 trial, which is a randomized phase 2 of CPX versus intensive chemo in patients with intermediate or adverse risk clinically defined de novo AML, so non-AML, MRC, or therapy-related AML. And this will be stratified by genomics. It's still not a technically all young patient comer trial, so the age is over 50, but we expect that there will be a lower age likelihood in this trial than in the original trial. Then the AMLSG 3018 is a randomized phase 3 of CPX versus intensive in patients with intermediate or adverse cytogenetics and therapy-related AML. This trial will enroll patients over 18. So again, not specifically designed purely for younger patients, but inclusive of younger patients that should help us understand the role of CPX a little bit better in this population. And then finally, let's get into a little bit of discussion about combinations with CPX. Dr. Kadia here was kind enough to share some slides with me, and he and his group have performed studies of CPX plus venetoclax in both relapsed, refractory, and newly diagnosed AML. This was recently published in the American Journal of Hematology, the relapsed and refractory study. And what you can see is really, I think, in this population, pretty impressive overall response rates of over 50%, with intriguingly high MRD negativity rates as well, higher than you would expect with really CPX alone or with really any regimen in relapsed and refractory disease. And then in the newly diagnosed setting presented at ASH last year, you can see that the same combo yielded, again, I think very impressive CR/CRI rates, and the majority of whom achieved MRD negativity and low early mortality rates. The overall survival benefit is not really clear yet, although the follow-up is still relatively short and the numbers are small, but certainly the high degree of activity in producing responses in MRD negativity, I think, raise a lot of interest in making this trial, this strategy, an important one for future randomized trials. This is the VFAST master trial, which is a 3-arm study that assigns previously untreated AML patients to various combinations of targeted drugs with CPX based on mutation profiling. You have your CPX plus venetoclax arm for essentially target negative patients CPX plus midostaurin in FLT3 mutated AML, and then CPX plus enasidenib for IDH2 mutant AML. The IDH2 mutant arm closed early due to a sponsor decision, not due to any toxicity signals. But the CPX and VEN and CPX plus midostaurin arm have reported out response rates, maybe a little bit lower than expected in the CPX plus venetoclax arm, but reasonably impressive in the CPX plus midostaurin arm. But again, a small trial, really kind of dose finding and kind of exploratory. And what was observed was that these combinations did not result in any meaningful prolongation of neutrophil or platelet count recovery compared to what you would expect with CPX alone. And then the question everybody's asking, and we'll hear more about, I think, in a few minutes with our other speakers, is whether CPX compares favorably or unfavorably to HMA venetoclax-based regimens. And not a whole lot of data so far, but in this retrospective study that used the Flatiron Health database, there was no appreciable difference in survival between Veneza and CPX-351 amongst the entire cohort and also amongst the cohort of patients that fulfilled the criteria for the original phase 3 trial that led to its approval. So early data that suggested there may not be much of a difference between the two, but not a randomized trial, and we all know that randomized trials are the gold standard for really identifying differences in outcome. There was some discordance in certain features, including the incidence of clinically defined de novo AML between the HMA-VEN and the CPX-351 groups, which certainly could play into the outcomes and the differences in survival or lack thereof that we're seeing in this particular retrospective analysis. There are randomized trials underway to help answer this question. I'm sure we'll be hearing more about them, but there's one that Dr. Fathi is running and I think has recently completed accrual. It's a randomized phase 2 for patients over age 18 with previously untreated AML, comparing HMA plus venetoclax against some type of standard induction, either daunorubicin plus cytarabine or CPX-351 in those patients with secondary AML. Event-free survival is the primary endpoint, but importantly, they're looking at some critical secondary endpoints, including MRD rates, rates of transplant, quality of life, healthcare utilization, which I think is going to be a very important issue, considering the fact that this is a somewhat time-limited therapy with CPX compared to maybe HMA venetoclax. So it'll be interesting and important to see the results of this study as they report out. So in summary, there's still a lot of unanswered questions. We still don't know exactly why this drug works in secondary AML. There's a lot of theories out there, one of which is maybe it overcomes multi-drug resistance, but those types of hypotheses have never been formally proven. So right now we're just left with the clinical observations. But many questions: will maturation of these targeted combinations yield further improvements? Can we add maintenance therapy to CPX-351 like we do with 7+3 with oral azacitidine? It seems to me like an ideal opportunity to look at maintenance, and there are some studies testing this right now. How will HMA-VEN and CPX be determined, their usage? Can CPX begin to slide into the MDS space more because of the high activity in the MDS-related mutations? And then will there be an appetite for next generation of randomized trials with this agent, given the fact that the molecular classification has changed significantly since the original trial was done, and it's going to be harder to really tease out the differences between CPX and other agents in randomized trials that are a little bit different than in the classifiers than the original trial. I would like to close by just saying some key features to me that favor CPX-351 are the fact that there is reproducible data now that shows that MDS-related mutations seem to be especially sensitive to this particular drug, and I feel that if you have a patient with an MDS-related mutation that's a good candidate for intensive therapy, CPX should be the drug of choice and maybe the overall drug of choice in any fit patient. It's a good drug to bridge to transplant with successful post-transplant outcomes. It's time limited, and there's the potential role for maintenance. I think we also recognize that it has pretty much no significant activity over anything else with TP53 mutated patients, and the HMA post-HMA therapy for MDS, we don't think that it's really active in that group either. So a lot of unanswered questions, but I think we do have a couple of new and developing insights with regard to specific subgroups that can help you understand which groups may benefit most from this treatment in your practice. So I think I tried to keep it within 10 minutes. That was hard to do, but thanks for your attention.